My name's Kathy Sherrington. It's my absolute pleasure to welcome you to this seminar from our Centre of Research Excellence on the prevention of falls injuries, which is a collaborative centre funded by the National Health and Medical Research Council in Australia. And so I'd like to start, of course, by acknowledging that I'm hosting this meeting from the lands of the Gadigal people of the Eora Nation here in Sydney, the traditional custodians of the land. I'd like to pay my respects to elders past, present and emerging, and recognise and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales and beyond. And I'd like to extend that respect to Aboriginal and Torres Strait Islander people who might be with us today. So welcome. So today we're delighted to have two speakers who have a lot of expertise on both clinical and academic. Anne-Marie's definitely academic, Rik's emerging academic, being enrolled as a PhD candidate. But both speakers have a wealth of experience in falls in a whole range of settings and particularly in residential aged care. And so first of all, Professor Anne-Marie Hill from the University of Western Australia, who's going to talk to us about physical activity and exercise. Can increasing mobility reduce falls in aged care? So I'll just stop sharing my screen. We'll let Anne-Marie get hers up and running. And then over to you, Anne-Marie.
Thanks, Kathy. And if I'm not sharing the screen properly, Kathy, just start waving at this point. And
that is perfect.
Okay,
we can
great.
hear you really well. So thank you.
Perfect. Thanks, everyone. And I'm going to talk about fall prevention, and hopefully you'll see as I'm talking and we lead up to what we're talking about that the link between fall prevention and mobility can sometimes not be as obvious to non-residential aged care workers as ourselves, I think. So what I hope to do is perhaps highlight that a little bit more today as we talk. So I'd first of all like to also pay my respects to Aboriginal people nationally in Australia. And I'd particularly like to acknowledge the Whadjuk people of Noongar Boodja, which is the traditional land where I'm meeting here in Perth today, and thank my PhD student, Miss Margaret Gidjup, who's a Noongar woman, for her beautiful artwork, which I can share to celebrate Aboriginal research and Aboriginal culture in WA. And I'd also like to thank and extend my respect to any Aboriginal people who might have attended the talk today. Thank you. I want to talk about fall prevention in residential aged care. And I want to particularly say at the outset that if we're going to address fall prevention, then we need to address barriers to physical function, because of how you prevent falls is also how you maintain physical function. How you maintain physical function will directly impact on the person's quality of life. So one thing I think I've learned over the years as a physio is that working as a physiotherapist requires me to do more than do my own physiotherapy. It really needs me to work in a systems level when I worked in residential aged care. And so I don't pretend to have the answers in this. And sometimes I think it's quite difficult, but I think it's really important that we aspire to it, because if we aspire to it, we'll move towards it. If we don't aspire to it, then we won't move towards it. I'm going to just start by saying, if we look at trends in hospitalised injuries due to fall, you can immediately see that the falls in residential aged care are significantly problematic, and the head injury rates are much higher in residential aged care, and rates of injury from falls are increasing. So at present, we can't say that we're on the right path and we're moving forwards, and so we need to keep on keeping on. We obviously still need to do something else. But what I particularly want to bring up down in this right-hand corner here is what the Royal Commission says about people who live in aged care or are receiving aged care, if they live in residential aged care or are living in having aged care services at home. They have the right to liberty, freedom of movement, and freedom from restraint. And so it is really important that as physios, I guess I'm speaking from my own perspective as a physio, but perhaps I should say as allied health practitioners, that we think about that first and foremost. I used to always say to my students, they would conscientiously tell me when I would go out to supervise them at residential care, well, I've got to help Mrs. So-and-so to increase her walking and she's going to get stronger. And I'd say, but what for? What is she going to do? What have you suggested is the goal? Because Mrs. Smith, you might be able to help her increase her walking, but is that to go outside to get in her daughter's car to go out? Is that for her to enjoy going outside into the garden? People need to be able to enjoy their life. And I think that's really important. I'm going to just emphasise here, when you look at age-specific rates of falls by place of residence, that you can just see visually what a significant problem it is in aged care. So again, it can be tempting if you have to think of this from the perspective of a relative just for a minute, it can be tempting to think, well, if my mother stays in her chair safely in her room, wouldn't that be safer? She'll be less at risk of falls than if she moves around. Whereas we know of all the evidence there is to suggest strength and balance, so increasing your movement is probably going to be the answer. So just to point out to you that even the AIHW report really takes care to significantly point out that rates of falls must mean that we need to specifically focus on this area. And I think this is a very significant gap that it behoves us to address. So when I talk about fall prevention in residential aged care, I'm just going to bring up a couple of systematic reviews, really to highlight that the evidence is very concurring, even though it differs slightly. You can see that exercise and multifactorial interventions and medications all have trends of effect or show effect. And of course, systematic reviews will differ a little according to how people gather their articles and what they put in the review and how exactly they classify everything. But for example, the very recent review by Gulka in JAMDA has found that exercise as a single intervention can reduce falls. So here we have someone saying, and concurring with other systematic reviews showing those trends, that if you become a person that's doing more, if you're doing exercise, if you're moving, you are less likely to fall. And we know ourselves that if you're exercising, you have a lot of mental health benefits. And we know that if you're able to mobilize, then you are able to participate in life more. So while I'm not bringing up slides related to that, we all know how important mobility is for quality of life. I'd like to just highlight a study done by a postdoc, a research fellow of mine, Jackie Francis Code, and she undertook to find falls prevention interventions in residential care that had very specifically tried to take a multi-level approach. So they'd addressed the staff and the patients and the organisation. And when she meta-analysed those, whilst there was some direction showing that they improved falls rates in that they reduced falls rates, what she found was that when you looked at trials that had had a significant effect, they were multi-level and they had shown that you could reduce falls and the number of people falling. They were trials where there had been extra significant input, like where people had paid someone extra to do that. So that really then behoves us to say, well, we do know some things that work in residential aged care, but how are we going to implement them? So let's get on to talking about mobility and exercise. It would be terrific if everyone had the balance of my grandson there as he marches across those ropes so gaily. But of course, we know that as you get older, your balance is reduced. So if you're going to maintain your balance, even maintain it, or if you want to improve it, you're going to have to focus on exercises that improve balance. Now, luckily for us, we have local Australian evidence, and this evidence led by Jenny Hewitt, about the benefits of exercise for people in residential care, and that falls rates were reduced when people did a significant amount of exercise. So really trying to follow an individual tailored program, making sure that people were able to do sufficient exercise. So rather than 5 minutes a couple of times a week, they were really able to do a meaningful program, and that really did reduce falls. Let's go on to then think about this physical function. I want to talk to you about this trial because I think it's a very interesting way for us to think about fall prevention and physical function. This was a trial done in the US where they looked at quite a large number of sites, 85 sites, and it did have some extra input. So right at the output, at the outset of discussing this, we can say, well, they've had to put in some extra input. How are we going to be able to sustain something if we require extra input in the financially constrained sector of residential aged care? And Rik will be talking about that more. But if you have a look at this trial, what they did was they put in a nurse facilitator, so not a significant amount of extra staff, and that person worked with a facility champion, and they worked with a stakeholder team, and they tried to aim to increase function and physical activity of the residents in a sustainable way. So they taught the direct care workers to evaluate underlying function and to optimize participation wherever they could. So they tried hard to make an embedded implementation intervention. And this is where they also took the effort, which I think, as I've said at the outset, is important, where they looked at policy, they looked at the environment, they looked at providing education. So they looked at creating an intervention that was wraparound. So rather than the champion go around and try to increase physical function via the direct care workers, they tried to make sure that there were some supportive structures in place around that. When you have a look at what happened in that trial, the intervention group showed less decline in function over time than the control group, so they were able to maintain their functional ability at the level they were at. And there was a significant improvement in the percentage of function-focused care behaviours by residents in the treatment group. So those residents who had the intervention at their site had more function overall in the day, more times to do activity. Now, I think that the reason this is so important is even if we as a therapist provide exercise for people, it won't be any good if it isn't backed up by some concurrent physical activity around in the week. If the person does 2 hours exercise and sits in their room with the door shut the rest of the time, we're not going to see the benefit of that. And secondly, as we said at the beginning, a person needs to have some goal. If I want to improve my functional ability and I live in a residential aged care setting, I'm not able to readily go somewhere and see my family. I'm perhaps not able to undertake some of the activities I used to. What do I want to increase my function for? What can I do? What is there meaningful for me to do in the home? What am I going to enjoy doing? And so that's, I think, a really important point and why it's important for us to look at physical function. Very importantly, there was no indication that the residents who were in the intervention group were more likely to fall. And in fact, there was some reduction in falls in the intervention group. Now, this was a pragmatic trial, so I think that's important, really. And in this type of intervention, I think it actually carries more weight for us, because whilst it's not a rigorous RCT, it shows that it's practical and is something we can implement. I'll just quickly mention vitamin D because I think it's important in terms of, I want to discuss with you implementation, and I think it's important as an example. We know that vitamin D is important and does have moderate evidence to recommend it for reducing falls and the number of people who fall in residential care. I want to just emphasise, and I've taken this opportunity at the last few talks I've done, because I've found that there are a number of family members and doctors who sometimes say to you, oh, but I've read somewhere, because this got fairly prominent coverage, and people who've read a single line in a newspaper have sometimes thought that it isn't useful to have daily supplementation of vitamin D. Now, it's very important to be able to instantly produce the factual account if that comes up. And we found in our big trial when we were trying to increase vitamin D that it did come up, sometimes by GPs. So it's important to remember that the US Surgeon General did recommend against daily supplementation, but when you read the document, they specifically say they exclude studies conducted in long-term facilities, and they specifically say the recommendations don't apply to these people, and they don't apply to people with a history of fractures and increased risk of fall. So if that comes up, I've just want to take it on myself these last few talks to specifically say that, so that you feel confident that you know where that comment might have been coming from, and you can just say, oh, that's fine, but that was only for community dwelling older people. It wasn't for people in nursing homes. So if we think about people with dementia too, it's important that we don't leave them out of this exercise equation. So as we're talking, we do want to emphasize that maintaining physical function is important for people with dementia, and there's no evidence to suggest they shouldn't, and there's actually evidence to suggest they should. So we include them in our discussion. So just talking about barriers and enablers, I think it's important in Gorka's systematic review that when you look at fall prevention interventions, and remembering that we're looking at exercise with those, most included studies often evaluate the intervention, but they don't establish that real world nature, which is why I think this trial by Resnick et al., where they tried to increase people's physical function in a practical way, is so important. Remember that there are going to be limited resources and workload issues in residential care. So we take that, but it doesn't stop us aspiring to work on implementation. I'm going to tell you some things that I think show that you can make changes, led by my postdoc fellow, Jackie Francis-Coe. We undertook a survey of care staff at residential aged care sites, and we found that only 26% understood that residents had an increased risk of falls. Now, there's something we can change. There are probably many more care staff at present who have no idea that falls are a significant problem, even though people are falling all the time. So that's an interesting point, isn't it? And there was also very small knowledge in practical terms of how you reduced falls. So I think that's something that can be addressed. When we audited 13 facilities in another big facility, we found that a lot of care staff didn't have access to an easy form of care plan that they could understand, and didn't really understand and didn't get formal reminders about falls. So again, these are things we can work on. So having a look at when we looked at across organisational levels, there are things we can do that we found weren't being done that could augment mobility and exercise interventions and falls reduction type of activities. So having a look and making sure you're doing things systematically across these levels can help you to sustain and implement good mobility interventions for the people that you provide care for. And I just want to show you this implementation of evidence using as an example vitamin D. these are some of the barriers that were found in a study by Williams et al. And we found these same barriers when we were working with our 13 facilities. Yet we found that by addressing them practically with championing, with education, and with local solutions, we were able to increase the proportion of people on vitamin D significantly across all 13 sites. So using practical implementation-based strategies, we were able to make sustainable and significant changes. And so that's the type of now implementation I'd like to look at with mobility. What can we do on the ground? Changing the vitamin D uptake in these nursing homes has been very helpful for them, because they initially, when we finished our trial, didn't see a reduction in falls. However, they are now commenting that they've noted a reduction in injuries, which naturally they're very pleased about. So let's also think about another thing we can do that can be done easily is we can work with the residents themselves where we can work with it. And we found that lots of our residents were very not understanding. When Jackie did a survey of people in Wales and Australia with another nursing home group in Wales, we found that many residents weren't really aware of what they could do. And I'll just get you to listen to this lady, Jean.
As much walking as I can.
And do you do any other sorts of exercise, Jean? Has anybody told you about doing some exercise to prevent falls? You know, keeping your legs strong?
Oh, way back, I think. A long time ago, I think we did some fall prevention. As much.
So you can see that this is a lady who's very motivated and interested, a lovely lady to chat with at one of the residential sites I visit. But she isn't really aware. No one has really spoken to her much about falls at all. And if we just look briefly at Jackie's summary here, you can see that lots of people were interested to talk to Jackie about falls and they wanted to stay mobile. But when we asked them about falls, they just said, well, there's really not much you can do about them, is it? And so these are people that were interested to find out things, but no one had really told them much about falls. And overwhelmingly, it was very important that they received a positive message. And so I think that's a really, really good thing to do.
Are you interested if anybody leaves health brochures or, you know, gives an event a bit of information? Are you interested in finding out things like that?
I know this is a difficult thing to say, but I have such a full life of things that I do. I do knitting for King Edward and for the Women's Refuge.
I think that clearly shows, doesn't it, that we're needing to make things interesting and positive, and contact with Jean about what can we do to help you maintain your independence. She's feeling a bit reluctant to go, oh my gosh, I don't want to do a lesson, but I'd like to really learn more about mobilising and keeping my independence. That's what we've found with our work. And I'm just going to finish up, but very briefly, I'd like to mention that when we talk about mobility, we're also doing some work with people who are receiving aged care at home. And I'm interested in these recent studies, and I don't have time to talk with you about them today, but they confirm with what a lot of what we're talking about with people here, is that a lot of times now when we're going out to the home, people who are receiving services are not receiving good mobility services. So their mobility is rapidly declining at home. And the caregiver burden is meaning that people are needing to move to residential aged care because the caregiver is starting to struggle with their mobility. So I'm just floating that as a very quick line, but I think this is something that we need to discuss, because we don't want people needing to move to residential care away from their home because they or the caregiver have lost their functional mobility, when maintaining that could mean they stay at home. So I'll just close on that, and I will going to quickly sum up by saying that, reminding you again that if we want to introduce a system-wide mobility improvement, we're going to have to tackle it at all levels. And I will just finish with one of our residents who I'd like to be the last person to give us her opinion.
So Val, what do you think while you're here at Bethany, what do you think is sort of most important to you so you can enjoy life? What's important to you?
That the staff treat me as a proper human being.
So,
and I think that Val really puts that so well. And that's why I think that person-centred care and giving people a reason to maintain their mobility is very important. And of course, I'd like to thank my research team in that everything I'm presenting, doing it as part of our grants, has been produced with the help of a very large and supportive team. So thanks, everyone. I'll just stop sharing now.
Thank you so much, Anne-Marie, and what a fabulous way to finish. So well done. So we've got a few minutes for to have some questions. Can I ask people with questions for Anne-Marie to either put your hand up or put a message in the chat, and probably your Zoom hand, because I can see that more easily. Oh, and Anne-Marie's happy to do the slide handout so we can share those. So that's fantastic. And the recording will be made available as well. So if there's no other questions, I'll start. Anne-Marie, I think that was so insightful. And I think it really is so important to be positive. We've got a very long way to go in this area, but I think if we can work together and advocate more. But I was interested in what you said about the multiple system approaches. But yeah, actually, I'll let Terry ask his question first. He's got his hand up.
Thanks, Kathy. I didn't want to cut you off there. Anne-Marie, the comment from the participant that my life is so full. Now, for a person who doesn't understand the aged care system, to me might come as a bit of a shock. Aren't they just sitting around? Aren't they waiting for things to do? And are they, shouldn't they be jumping at the chance to do falls prevention work? Just being able to reconcile with the aim that we have as falls prevention researchers to want to reduce falls, but also being able to get that on as a priority for the person in an aged care facility. How do you recommend trying to help them, I guess, to get it up that priority list for them to see that it's something that's potentially valuable, something they'd want to engage in?
Yeah, I definitely think that's important. That was what Jackie's research found as well, and what we've been discussing with the residents that we're working with now who get aged care services but at home, is that we need to, people are seeing falls still as a very negative thing, and they are wanting to avoid falls, but they're more just seeing it as still the self-blame, like, oh, it was my fault for falling. And the message they're getting still very much is that falls, the way you'll reduce falls is just to wait for us to come and help, which is problematic then because there isn't that frequency of help. And so we're very keen to take some new positive messages to people about how they can take control themselves, but also what I'm very keen for us to do now is to look at falls in a way where we mention to the person that the first thing I'd like to see us actually say, we're independence researchers. I'm really keen now to talk to people in residential care saying, we're here to help you maintain your independence. And we talk about exercise, and we talk about to family about vitamin D, and we talk to the resident about medications if need be, and we do those things. And we say, and concurrently, those things actually reduce falls as well. So I think it's, above all, everyone we speak to wants to maintain their independence. And so I think that's a really big hook for us to get into. And understanding, giving people enough warning initially about, the concept of moving around more will be helpful for you.
Fantastic. Thank you, Anne-Marie. We might move on to Rik now, and then we'll have some more time for questions and discussion at the end. And so, yes, introducing Rik Dawson, a PhD candidate and experienced physiotherapist. Would you like to share your screen, Rik?
So thanks, Kathy, and it's great just to have to follow Professor Anne-Marie Hill. We share so much in common about being positive about what allied health and physio and what we can do in fall prevention. And just want to shout out, there are people in the audience that I've worked with in the past, so nice to see a wide group. And today I just wanted to say thank you to the CRE for my scholarship to do my PhD, which is on the top-up study. And I thought it would be good for me to give a little bit of an update about why I decided to do research, where top-up is, and looking at what's happening in residential aged care in particular with all the reform that's going on post-Royal Commission, where my research or our research will land in the marketplace. And I will just, yep. So, I ran Age Well Physio with my wife for many years, and we spent a large part of our practice was flying physios out to regional remote areas because there just weren't the physios out there at the time to service residential aged care. And there's a photo here of my dad with my grandfather. They were both born in Bourke, and the number of times I'd go to Bourke for different family events, and the local facility would say, "Rik, can't you get somebody to come out, or can't you?" But the reality was, by the time I flew to Dubbo and hired a car and drove to Bourke, it was so expensive. It just wasn't really worth the layout of the money, which is a really sad issue. But that workforce and access issues in Australia is a real problem. The other issue I used to have is that we would go out once a month or once every 6 weeks, and we would do assessments, and we would do some telehealth in between. We used to do FaceTime and talking to the staff at the facilities, keeping the program sort of progressive in nature. But how did we get these older people to do some really good standing strength balance exercise, which we know from one of my supervisors, Kathy, who's chairing today in her community, you know, progressive standing strength and balance is important. Could we start to explore some of the online exercise opportunities that we were seeing in other markets? But as a part of my role with the Australian Physio Association has to do a lot of the aged care advocacy. And anytime I spoke to the Department of Health or to ministers or senators, as our previous aged care minister is shaking my hand here from last year, they wanted to see research that had cost effectiveness aspects. But they also wanted to hear some client stories about how our research is really making a difference on the ground. Then COVID hit, and all this hesitation about telehealth that was, I had so much feedback, you can't do telehealth for older people, they're not cut out for it, it's too hard. But basically COVID hit, we thought it was going to hit for 6 months. It did force us online, and it really changed the way the health sector saw physio in particular. We became part of the essential workforce instead of an optional, and we got the telehealth options. So now the challenge was, how do we implement telehealth in aged care? How do we do it practically for all those exercise professionals out there working in the space? And the space we're working in today is pretty unsupportive of allied health. As you can see, I think the average spend under the aged care funding instrument, which is the current funding instrument that is scheduled to run out in October, around the $250 average spend, they don't spend much on allied health. And in fact, when it looks at how many minutes each resident gets per bed per day, it's only 15. And when we talk about allied health, that's physio, that's OT, that's diversional therapy, lifestyle, you know, Cert 3, Cert 4, we all get lumped into this term allied health. And a lot of different layers of allied health have issues with, you know, physios being compared to Cert 3 allied recreational officers. And one of the interesting things that Kathy Eger at her team at Wollongong Uni found that there's less than a minute spent with our residents on restorative care. That's the falls prevention work that Anne-Marie was talking about before. And at the moment, the dominant allied health is pain management under ACFI, which is about 8 minutes per resident per day. But when you look at, and obviously physio is a big part of that. So we're spending a lot of time not doing the stuff that we know and think we know that reduces falls. And what I noticed over the 15 years that we had ACFI in is that before ACFI, physios in particular used to work really well with therapy assistants, designated care staff that were trained to deliver the mobility and falls prevention programs. And we used to get really good results, but ACFI had no funding for therapy assistants, so they faded as a workforce. And it's a bit of an indication, if you don't fund something, it's not there. So the top-up study, the genesis is pretty much what I've been talking about. And it's, we want to look at how physio telehealth intersects with aged care, residential and home care. And it's been designed to be a level 1 hybrid effectiveness and implementation, because I want to come out of the end of my PhD with some tips to clinicians about how we use telehealth effectively. So we're planning for it to be 240 participants, of which half we want to be in residential and half in home care. And there will be a waitlist control. So those who are the control will get offered a shorter program at the end of the trial. And it is a 6-month intervention following on from Jenny Hewitt's work on the Sunbeam. And we followed the Consolidated Framework for Implementation Research to design our protocol. And I just wanted to show you really quickly the really pragmatic way of looking at designing a research protocol. And we look at the people that will be our participants and, you know, what do they know about telehealth and exercise in regards to mobility and falls prevention. And so we ran about 3 or 4 different workshops with, you know, real live participants and asked them for their views. Have they used telehealth? What did they think? What did they think could be useful for them? And then we looked at how we would roll out telehealth. And that's when we got involved with our aged care partners, of which Widden and Uniting Agewell and Ashfield Baptist Home have been so influential in helping us co-design our protocols so that we could roll it out in their sites as a part of the trial. And so then we started looking at the interaction of the environment that we work in. So knowing that a lot of older people aren't technologically confident, part of our protocol is making sure that they would have that local support with the telehealth, but also with the technology and also with the exercise to give them the support. And then I talked to my aged care partners about how they would support that and how much they could support. And hence the reason of looking at the setting of aged care. So it's a really great model and really useful. The highlights of the program are 10 physio sessions over 6 months. That's delivered by a physio. At the moment, we've had 6 physios as well as me deliver the intervention to date. And it's program development and it's health coaching. So we're showing the residents what to do, how to do it, and to show them a little bit about why they do it. Building on what Anne-Marie was talking about, it's a constant education, nurturing style of program. We've developed an app, a website with 9 exercise videos based on the Otago, but we were very kindly given the permission by Neura at University of New South Wales to use their Standing Tall app, as well as our traditional booklet. We have been running group exercise classes, and part of that is doing some Zoom exercise with the local coaches on the ground in the facilities to teach them how to do good standing strength and balance exercise classes. And as you can see, the top-up coaches are really important to the success of this intervention because they're going to help the clients Zoom with the physio every 2 to 4 weeks. They're going to be with them at least weekly to access the technology, to watch the videos, to help them exercise in some of the more challenging exercises that the physio may be wanting them to try, motivate them and keep it safe. And here are our outcomes. So our mobility outcome is our primary one, but falls is part of our secondary effectiveness outcomes, as well as a quality of life survey and goal attainment. We will be doing an economic analysis with the help of another PhD student, and we are really looking at the implementation related outcomes about why do residents stick with these programs, what are the barriers and facilitators, and a few other issues pertaining to sustainability and telehealth post the trial. So we got 94 enrolled, and we're really fortunate at Christmas, a little present from Dementia Australia, some funding to work with some aged care physio businesses to pragmatically roll this trial out through their businesses. We've been really fortunate to have very generous aged care support to date and ongoingly into next year, with providing us with iPads and that weekly care staff, which does add up. And we're getting some really good stories to, show the new government that has just come in about the usefulness of telehealth, and also the importance of exercise as a part of a falls prevention program in resi care. We've had no serious adverse events to date, and we've had good exercise adherence. We've had about 1 hour of strength and balance per resident or per participant per week. And what the participants are just loving is the local support. But they are doing some of their independent exercise, and that's something I really want to focus on the second phase of the recruitment that starts in a couple of weeks. Some of the challenges, working with people with dementia, we wanted to be a pragmatic trial, and we wanted it to include people with mobility and cognitive impairments, and we did get ethics to accept moderate. COVID has been an enormous challenge and continues to be a challenge. It has reduced our recruitment. It has caused quite a lot of loss to follow-up with the deaths. We've had quite a few withdrew due to COVID-related issues and staff issues, and we've just lost 6 weeks on average of intervention due to COVID. But we also had the added disadvantage of floods in a couple of the sites that we're working with in northern New South Wales. No, infestation of mice or anything dramatic, but you never know what's going around the corner. And the question I have, with all the changes that are happening in resi care at the moment, will there be funding for telehealth and exercise to improve mobility and reduce falls? So Marie said, we've got a lot of people that use aged care services. Most of the aged care service users are people receiving Commonwealth home support. And now we're approaching about 240,000 accessing, we'll be getting up to close to 200,000 for home care packages. And we've got more in residential aged care. There's a lot of respite, and at the moment there is really no active or allied health involvement in respite beyond basic lifestyle programs. And what's going to happen to short-term restorative care with all the reforms that are slated to take place 23-24 for home care? So there's going to be a lot that's going to influence what we do in home care, keeping people well at home. But today we're going to focus on resi care. Interestingly, when you compare us to some of our neighbours or our similar socio-demographic countries, we have quite a high proportion of people 80 plus who use residential aged care. But when it looks at how many beds that we have for people aged at 65 and under, we're a bit lower. To me, that suggests that we probably do a really good job at keeping people at home well and delaying that entry into resi care. But it's a significant part of the aged care service model, and it will be into the future. This slide was developed by Professor Kathy Eager as part of the Royal Commission in 2021. She was talking about all the different recommendations that a lot of the the industry has put forward in the Royal Commission. And she talks about the reform in the inputs to the residential care system, some of the processes that shape change, what actually influences the outputs and the outcomes. And so she's done a lot of work at developing some of the new funding instrument that will be starting in October, and I'll be touching on that in a second. But one of the big items that came out of the Royal Commission is that when we look at Australia and our average care staff minutes, we were below average. We were, most of our sites were really at 2 out of a potential 5-star. We just didn't have enough care staff minutes caring for the residents. And in particular, the Liberal government decided to mandate a 200 minutes total, which will be starting in July 1, 2023. But interestingly, Labor government in their pitch to become our new government in this year, they matched the 200 care minutes, but they also said that we need a minimum of 40 minutes of registered nurse over a 24-hour coverage, which is an enormous undertaking for the industry, because that means that the industry is going to need to find another 10,000 RNs in 23 to deliver this 40 minutes. And when you think about what Kathy Egger said a little bit about the inputs, it's the amount of care, but it's also the mix of care that's important. And this is where I feel like, and the Australian Physio Association, this is where we feel they've got it wrong. There's no inclusion for allied health. And we feel like we are an essential part of the care delivery in residential aged care. And I do a lot of work with different providers, and a CFO of a leading for-profit aged care provider said, if the government doesn't see allied health as an important part of RACF, therefore we don't need to deliver it. So I just need to just hide one thing here. When it comes to influencing care, we've got the Accreditation Quality and Safety Commission with the 8 standards, but something that's happened this year is that the Australian Commission of Safety and Quality, that's primarily focusing on the safety and clinical issues related to hospital, has been tasked with developing the similar standards across aged care, resi and home care. And the CRE has been commissioned to do the work around falls prevention. And really what they're going to be doing is looking at developing processes and resources for the aged care service providers to deliver the best practice, evidence-based falls prevention care. But there's been a lot of criticism around the accreditation process, that it doesn't really look at resident outcomes. It's very much about the paperwork that goes into developing the good care. So there's a lot of feedback around the effectiveness of the standards as we see at the moment, but I'm confident that the new National Safety and Quality Health standards are going to make a big difference in giving resources about best practice care. So what creates outputs, in my mind, is funding. So if you want a service delivered, you need to fund it. And so there's going to be a new national aged care classification that will be starting in residential, and there is talk about developing a system for home care as well, once home care has amalgamated with Commonwealth Home Support and respite and short-term restorative. And there's so many positives around AN-ACC to replace the outdated ACFI, in that it separates assessment for funding from care planning. So essentially ACAT and other service providers will be doing the assessment. That will leave the care planning and the care delivery and the care processes inside the home. They will be able to get on and to do with it, which would be really good. And it's going to be based on residents' needs, strengths and preferences. And that AN-ACC, that external assessment, will be done by RNs, PTs and OTs. And so it's going to be a really, and what's really nice about the new AN-ACC, it's going to take into consideration regional, remote, and some of those facilities such as Indigenous that have higher needs, and they will get funded accordingly. And so 50% of the price will be about keeping the lights on in the building, which is quite similar from a facility where I live in Linfield in Sydney to the one in the next suburb, but was going to be quite different to, say, the facility in Bourke that might have a high Indigenous population, or a facility that has quite a lot of, say, homeless or mental health problems. And then the AN-ACC will decide what the variable price per day for each of those individuals will get. This is how the tool has been created, and it was created by Kathy Egger and her team at University of Wollongong. And it's a branch funding tool, and the assessors will look, the first branch will be mobility versus palliative care. But basically it looks at the really high costs of care, and you'll get a classification, and then you'll get a variable funding associated with that. So after palliative care comes mobility, then comes cognition, and then comes sort of those higher end sort of specialised nursing needs and compounding factors. It's a little bit complicated, but what's really interesting is that they've decided that mobility is a really big driver of cost of care. So keeping someone independently mobile is a real positive. And one of the benefits of this system at the moment is if you come in as a not mobile and you provide really good allied health, and you get them up a level into assisted mobility, which essentially means that they'd be cheaper to look after. The government is not going to penalise you and do another assessment and redo your funding. You get to keep the original classification. It's an incentive, but it's not funding. Other influences of outcomes are the national mandatory quality indicators that started last year, of which falls is one. And it is all facilities now need to keep a track of how many falls and injuries, and it's going to be able to be accessed onto the aged care website, so people can see, oh, this facility has a high amount of falls, this facility has low amount of falls. Now, there's a lot of challenges around the way the national indicators are at the moment, because we do know one facility is not going to be the same when it comes to falls for the next facilities, but it is a start in a journey of benchmarking quality indicators and outcomes according to the types of facility that you are. But at the moment, it's very hard for the consumer to understand the difference between facility A and B just purely on the falls rate. And so what's going to happen? There's no funding for allied health. There's no specific funding for allied health. There's been a lot of criticism about the funding for ACFI, about pain management being really passive. And I suspect what will happen is that we'll see growth in allied health assistants, because they're considered part of the care team. Allied health at the moment are not considered part of the care minutes, which is, you know, poor. I think that's just a poor insight into the government about what allied health does. So we'll see growth in allied health assistants. We'll see growth in lifestyle programs pertaining or promoting themselves as being evidence-based and really driving outcomes, when we know that they probably don't have the skills. So there'll be lots of, you know, seated exercise programs that we already see. And what will happen is that allied health will probably stay in the system as assessors internally, but we won't be given any opportunity to do any restorative work. We'll be asked to do group pain management programs because it's cheaper than one-on-one. So without the funding, it's going to be really hard to deliver evidence-based programs like Sunbeam. And that's where the APA has come in and said, we want to be a part of the care staff minutes. We want our own minutes. There's a lot of talk at the moment, should lifestyle, physio, so APRA registered health professionals and TAFE trained care, therapy and lifestyle assistants, should we come under the one umbrella? What's perfect, what's good? Everyone will have their own opinions, but at the moment, the APA is really specifically asking for 10 minutes, because at the moment we know that allied health is probably doing about 10 minutes now, and we would like to keep that 10 minutes to at least do what we're currently doing and pivot from passive pain management and to take those 8 minutes into some restorative falls prevention work. We have asked for additional funding for restorative and reablement care to maintain mobility, independence and reduce falls. I don't think we'll get it, because I think it's despite asking for many, many years, the government is not interested in funding separately. But because of COVID, there was a national rollout of the Sunbeam program to COVID-affected facilities in 21 and 20 that has about to wrap up. And there was about 200 facilities that participated in that trial, of which about 30 to 50% of the residents participated in what they call a Sunbeam Mark II, where they don't use the expensive HER equipment, but more traditional weights and TheraBand. But that report that will be prepared by NAS to talk about the effectiveness of that program, I can't see being advertised until next year. And I suspect the government will want us to roll out AN-ACC and just see how the industry goes. And that's pretty much what I've been told. Research is super important because it's going to give solutions to policymakers. And so that they understand how best to support our older people to age well. And so that in my particular research, you know, can telehealth plug that gap that regional and remote Australia are missing out on in a cost effectiveness way? And I don't know if we've got a couple of minutes. I just want to show you, like Anne-Marie does so beautifully, shows resident stories. We did a story last year during COVID about the effectiveness of what we at Allied Health do. And here's a participant of mine from the facility in Ashfield. Hi, Rita. Thanks so much for giving up your time today, talking to everyone.
It's fine. I'm enjoying.
Just if you can give everybody an idea of where you're living at the moment.
I'm in an aged facility in Ashfield.
And how long have you been living there for?
Since the 6th of February last year.
And how are you managing to stay active at this time, especially now that we have COVID and lockdown in Sydney?
I make sure that I always have breakfast and lunch in the dining room. So you move, you go and you having lunch with other people. But I also make sure I walk around in between times, go walking around the facility.
That shows great initiative. Are you attending any group exercise classes at the moment?
Yes, I do group exercises Monday and Thursday, and I do your exercises Monday, Wednesday and Friday.
So you're doing a lot of exercise at the moment, which is great.
Yes, it's really good.
And how does being active benefit you?
I think it benefits me in every way. It benefits your brain because it makes you get out of your chair, move around. And otherwise, if you sit in the chair, even though you're not getting bored because you have so much to do, and I never am bored, but you vegetate. So you need that movement, and you need to see the different parts of the facility, not just your room. Even though my room's lovely, you need to see the different parts.
And you've been starting some telehealth with me. How are you finding it? What's your initial impressions of telehealth?
I love it. I love it. 2 weeks ago, I could do 5 sit stands, and today I did 20. So I felt as though I was flying.
And I just wanted to say thank you. I just wanted to share a little bit about Rita. They're the sort of stories I think were so successful in the Royal Commission to get the community to understand what was happening and the challenges that staff were facing, but also where substandard care was. And just on a little personal note, I'm very excited that Top Up has started at Burke 2 weeks ago. It's a small facility of only 12 residents. I had intended to enrol all of them, but only 4 wanted to enrol because there's still a lot of hesitation around telehealth. And here's just a couple of the residents who have started as the intervention. And they're, as you can see, super excited to stay mobile and improve their mobility and reduce their falls. So that's me. I just wanted to say thank you to my supervisors, Kathy, Abby, Juliana, Marina, but also there's a lot of contributors that have really helped me develop my protocol and get this project up and running, such as Bazi, Kim, Morag, and Leanne. And I just want to say thank you to all my aged care partners, for which I couldn't have done this or couldn't be doing this without their support, financial and in kind. That's me. I'll stop sharing my screen.
Fantastic. Thank you so much, Rik, and how wonderful to hear from those participants as well, or that participant. We've got just a couple of minutes. Would anyone like to ask Rik any questions or have any comments?
There's a question in the chat from Anne-Marie, Kathy.
Oh, yes. Anne-Marie, do you want to verbalise your question?
Oh, I just think Rik has pointed out the perfect, we said about we won't be able to improve mobility if we don't have these other areas around us that operate as, organisation level, system level support around us. So I do think it's really important that we work out how we are going to be able to get funding into allied health for aged care. And, so I think it's really something that we could drive as a group. And I'd be very interested, one of the things that I would point to most is to say, if we could gain a powerful enough lobby group that included consumers who have themselves or their family members in aged care, I think they would be people that we could produce reports and drive. Using those consumers could really help us to drive the message home about people's quality of life. So I think that's an important aspect. I think when you have when you know that your family member has moved to aged care, and within a very short time you see that their mobility is going down, and you quickly realise that that means their quality of life is going down. To me, those are really important points.
Well said, Anne-Marie. We've got two people with their hands up. I might let the president of the Geriatric Medicine Society jump ahead. So, Vasi.
That was great, Rik. I'm still worried. So this is with my NZSGM hat on. I'm still worried that people, the comment you made at the beginning, I'm still worried that people don't understand that it's about the health, stupid, right? That people in residential care, people requiring services, the reason ultimately comes down to the fact that they've got health problems. And, they're talking about, at least for ACAD assessments, that you could probably outsource this and ultimately privatize this. And the worry is that it'll be dumbed down. So there won't be people assessing for health problems, potential for rehab, reversibility and so on. It'll, it's still a challenge to get everyone to understand the importance of health and reversibility.
And Vasi, I totally agree. We've said to the federal department, if we don't look after these residents well, they go to the hospital and are incredibly expensive to cater for. But I think the problem with Australia is the federal-state divide. Federal look after aged care, and they obviously they direct taxpayers' money to the states, but it's not their responsibility. So there's a real disconnect between maintaining great health in resi care to stop that expensive drain on the acute system. But they don't get it, in my opinion. They can't connect the dots.
Well said, both of you. We're just running out of time, but I'll let Terry speak briefly.
Just quickly, Rik, interested in your comments and your thoughts about allied health assistants being considered a part of the aged care team, but not the therapists. Is this something that you think is evidence-based, or is this purely being driven by financial pragmatism on the part of the government, thinking that they'll get a bigger return on investment from employing allied health assistants than allied health practitioners?
They're cheaper. Because they will be considered part of the care minutes. It's an opportunity for the industry to bump up to their 200 minutes, not just have the assistant and nurses. They can have assistant in therapy. Is there evidence? Look, part of what I'm doing is working with care assistants to deliver evidence-based programs. There's not a lot of evidence saying these programs can run, but without there's been no talk about supervising these therapy assistants, and and we've got somebody from New Zealand saying they have physio assistants in widespread use. So there needs to be more work done on what models, because the Sunbeam program was physio-led and physio-delivered. So and that's what reduced falls by 55%. So at the moment, we know it's allied health professional that is the important link, but whether there are other models that utilize allied health assistants. And Jessie, I'm coming over to the New Zealand conference in September, so if you're there, you should find my email and email me. We'll chat.
And it'd be great to facilitate further discussions through the CRE, I think, in terms of models that can work, and also in terms of how to unite our advocacy voices. So thank you so much to two excellent speakers and a great attendance and great participation, excellent comments and questions, and look forward to seeing you all again. Bye-bye.